Every single morning across this country, millions of older adults stand next to their kitchen counters. They swallow a small prescription tablet. Then they go about their day. They do not give that chemical a single second thought. But if you or someone you look after handles a daily blood pressure routine, I need to ask you an important question. What if that tiny ordinary tablet is quietly changing far more than just your blood pressure numbers? There is a massive difference between reading the black and white warning text printed on your pharmacy bag and truly understanding how this medicine affects the rest of your body. Most people treat their morning pill like a daily vitamin or a harmless habit. But these medications are powerful medicines that affect many systems throughout your body. They actively manipulate the workload of your heart. They alter the fluid movement within your blood vessels. They even change how your kidneys handle life-critical minerals every single hour of the day. Yet the vast majority of seniors take them on absolute autopilot. They are completely unaware of the subtle, creeping symptoms that mean your internal chemistry is starting to turn on your health. We are breaking that autopilot cycle today. My name is James Bennett. I am a senior health data researcher and curator, not a doctor. I do not write prescriptions, and I do not operate in a hospital. Instead, I spend my life analyzing public health data, medical registries, and peer-reviewed trials. I do this so I can bring the raw, honest truth straight to you. This channel, Clinical Insights, is dedicated to giving you the exact practical safety data that almost always gets left out during a chaotic 10-minute doctor's checkup. By the time you finish this review, you will possess a wave of health intelligence. It will make you significantly safer, more confident, and better prepared to spot potential problems before they become serious. Let us begin by looking at a real tracking record belonging to a 72-year-old retired high school mathematics teacher named Arthur Jenkins, who lived in Columbus, Ohio. For over 5 years, Arthur managed his morning routine with absolute precision. He looked at his health numbers like a seasoned data analyst. On a digital computer screen, his medical chart was an absolute work of art. His resting blood pressure sat flawlessly inside the rigid target zones demanded by standard clinical charts. His primary care provider was completely satisfied. But out here in the real world of everyday life, Arthur was unknowingly stepping into a silent, drug-induced kidney trap. Arthur was a careful man who took immense pride in maintaining his independence. He loved spending his summer afternoons completely losing track of time while building custom oak furniture in his backyard workshop. But during a particularly brutal July heat wave, a slow and dangerous shift was taking place inside his body. Arthur noticed that his lower back and knees were aching intensely from standing at his workbench. To manage the pain, he did what millions of adults do without thinking. He reached into his toolbox and swallowed 3 standard over-the-counter ibuprofen tablets. He washed them down with just a few sips of lukewarm water. Less than 48 hours later, Arthur woke up experiencing a terrifying wave of confusion. When he tried to step out of bed, his legs felt completely heavy, like lead weights. His vision began to dim. He tried to call out to his wife, but his voice was completely raspy and faint. Within hours, his family rushed him to the emergency room. There, the medical team discovered that his kidneys were rapidly shutting down. Arthur was in acute kidney distress. This did not happen because of a new disease, and it was not because of old age. It happened because the ordinary pain pills he took for his back stiffness had triggered a catastrophic chemical clash with his daily blood pressure medication. Fortunately, the hospital care team identified the exact chemical trigger in time. They cleared the toxic combination. They stabilized his fluid levels. They completely changed Arthur's understanding of how prescription chemistry operates in an older body. His experience serves as a critical protective blueprint that every senior adult navigating these daily prescriptions needs to hear. The hard truth is that Arthur's chart looked beautiful, but his daily routine was quietly endangering his vital organs. To understand why this happens to millions of careful adults, you must learn what I call the dose assumption trap, which is built upon three distinct structural pillars. Pillar number one focuses on the origin of clinical guidelines. When your provider selects a standard daily dose, they follow official charts. But those baseline clinical safety trials were originally validated on studies involving individuals who were in their late 40s and early 50s. They were never designed for a 78-year-old heart and blood vessel system that processes compounds at a radically different speed and might be navigating three other maintenance prescriptions. Pillar number two exposes the symptom illusion. The precise chemical dosage required to force your blood pressure digits to look pristine on a medical file may be the exact same dosage that is quietly creating daily physical constraints. Chronic, dragging fatigue, sudden waves of unsteadiness, mild cognitive gaps, and heavily swollen ankles are not mandatory, inescapable milestones of biological aging. They are frequently side effects hiding right in plain sight. Pillar number three highlights the data disconnect. Controlled blood pressure inside an electronic health record does not automatically translate to optimal blood pressure for your actual living, breathing body. A static number that looks spectacular inside an office folder might be making your daily living experience profoundly worse. That is the core of the trap. The charts look fine, so everyone assumes the chemistry is fine, and nobody ever stops to ask how you actually feel when your feet hit the floor in the morning. To break out of this trap, we have to look under the hood of the three most widely prescribed blood pressure medications in the world. And we need to start with a class that handles chemistry through a very specific enzyme pathway. Let us look at lisinopril. Lisinopril is an ACE inhibitor. It functions by intercepting a very specific enzyme in your body, preventing it from manufacturing a highly potent constricting hormone known as angiotensin II. Without that hormone circulating in your system, your blood vessels stay wide open and relaxed, which forces your overall blood pressure down. Now look at how that compares to losartan. Losartan is an ARB, which means it is an angiotensin receptor blocker. It works within that exact same hormonal system, but it handles the process through a completely different door. Instead of stopping the production of the constricting hormone like lisinopril, losartan acts as a physical shield. It lets the hormone circulate, but blocks it from ever binding to the receptor sites on your blood vessel walls. Finally, consider amlodipine. Amlodipine belongs to an entirely separate family called calcium channel blockers. It bypasses the hormone system entirely and works by directly relaxing the tiny, smooth muscles built into the walls of your blood vessels, allowing them to expand so blood can flow with minimal resistance. This specific science matters immensely because every single one of these individual drug mechanisms carries a completely distinct profile of cellular side effects, nutritional depletions, and dangerous over-the-counter interactions that grow significantly more disruptive as we cross the age of 65. This leads to your very first critical action step for your next checkup. Look your care provider in the eye and ask this precise question. Why did you choose this specific class of medication and chemical pathway for my body instead of one of the alternative options on the market? If you do not receive a personalized explanation tied directly to your unique kidney function or circulation history, that is your signal to dig deeper. Let us isolate lisinopril first and break down a notorious side effect that represents a profound quality of life crisis for millions. This is the chronic dry cough. This isn't a typical productive cough that clears congestion out of your lungs during a cold. It is a constant, scratchy, highly sensitive tickle located at the very back of your throat. It almost always intensifies the exact moment you lay your head down on the pillow to sleep, and it completely ignores over-the-counter cough syrups, medicated lozenges, or strong allergy medications. What makes this reaction incredibly deceptive is that it rarely starts the first day you swallow the pill. While a few individuals notice it within a week, for a vast number of seniors, it takes 3, 4, or even 6 months of continuous daily therapy before the cough suddenly surfaces. And by that time, the connection to their morning blood pressure routine never even crosses their mind. They blame household dust, seasonal tree pollen, acid reflux, or a lingering irritation from an old cold. Consider the record of a 71-year-old avid gardener named Evelyn. When her dry cough first manifested in late spring, she logically assumed it was a standard reaction to seasonal oak pollen. She spent a small fortune on high-end household air purifiers and daily antihistamines. She eventually mentioned it to her doctor, who ordered a routine chest X-ray that came back completely clear. 6 months later, the hacking cough was still present, completely disrupting her sleep patterns night after night. Evelyn was chronically fatigued, highly irritable, and starting to stay awake in absolute panic, terrified that an undiagnosed lung issue was being missed by her care team. When Evelyn's data line was reviewed, the very first thing analyzed was the chronological timeline. She was asked this question: when exactly did you start your lisinopril relative to the week that throat tickle first appeared? She went silent, pulled out her health diary, and did the manual math. She had started her lisinopril 11 months prior. The dry cough had appeared almost exactly 4 months into the treatment. She had never once connected the dots. Once the chemical culprit was identified, she worked with her primary care team to transition away from the ACE inhibitor and onto losartan, which manages pressure beautifully but leaves the respiratory pathway completely untouched. Her 11 months of sleep disruption and vocal irritation vanished completely in less than 2 weeks. Here is the exact biological reason behind this issue, detailed extensively in the New England Journal of Medicine. When lisinopril blocks that specific enzyme to lower your blood pressure, it also inadvertently stops your body from breaking down a natural inflammatory substance called bradykinin. Because the enzyme is blocked, bradykinin begins to abnormally pool and accumulate directly inside your respiratory tract and lung tissues. This chemical buildup makes your airways highly sensitive, creating a chronic, dry cough reflex that no cough medicine on earth can silence because it is not an infection. It is a localized chemical accumulation. Now, while a dry cough is a severe nuisance, you must draw an absolute unyielding line between a daily irritation and a medical emergency. If you are currently taking lisinopril and you develop any sudden swelling of your lips, your tongue, your face, or the inside of your throat, especially if breathing or swallowing begins to feel tight, you do not wait for an office appointment, you do not call the clinic tomorrow morning, and you absolutely do not take an allergy pill to see if it passes. You call emergency services instantly. This is a structural condition known as angioedema. It is rare, but it is deeply real, and it can close an older adult's airway faster than you can react. A dry cough is a reason for a calm medication review. Throat and lip swelling is a 0-second emergency. Please burn that distinction into your memory. If nobody has ever broken down your daily heart prescriptions with this level of analytical clarity before, hit the subscribe button right now. Our next point involves losartan and a danger that is completely counterintuitive because it stems from seniors doing what they honestly believe is the healthiest possible choice. Losartan, because it blocks the angiotensin receptors, exerts a powerful secondary effect on your waste management system. It directly alters how your kidneys manage a critical mineral, which is potassium. It turns down a chemical signal called aldosterone, which under normal circumstances acts as the lead manager for your kidneys, telling them exactly when to flush excess potassium out of your body through your urine. When your daily medication turns down that signal, your kidneys receive less instruction to clear the mineral, and as a result, potassium stays trapped directly inside your bloodstream. Now, layer that exact mechanism over the natural realities of human aging. As our bodies grow older, our baseline kidney filtration rate naturally and gradually declines. This means an older pair of kidneys is already fundamentally less agile at clearing metabolic waste from the blood. Then look at what health-conscious seniors are actively eating every single morning. Fresh bananas, raw spinach, baked sweet potatoes, and fresh avocados. These are all heavily celebrated as heart-healthy foods, but they are all packed to the absolute brim with natural potassium. And here is where the silent trap snaps shut. These are commercial salt substitutes. An older adult is told to cut back on sodium to protect their heart. They go to the grocery store, head to the spice aisle, and pick up a popular low-sodium salt alternative that is explicitly branded as heart healthy. But if you turn that bottle around and look at the chemical label, you will find that these products replace sodium with potassium chloride. So a senior is now liberally shaking pure potassium onto every single meal, eating avocados and bananas while taking a daily dose of Losartan that is actively blocking their kidneys from flushing potassium out. The clinical term for this dangerous accumulation is hyperkalemia, and data published in the American Journal of Kidney Diseases confirms that emergency hospitalizations linked directly to drug-induced hyperkalemia among older adults are steadily rising year over year. What makes this truly frightening is that high potassium is completely silent. It typically presents with zero external warning signs. You do not feel it happening in your muscles until the electrical voltage of your heart muscle becomes dangerously disrupted, triggering a sudden, life-threatening, irregular heartbeat with absolutely no advance warning. Here is your critical safety protocol. If your daily regimen includes losartan or any drug within the ARB family, you must have your blood potassium levels and your estimated kidney filtration rate checked via routine laboratory blood work at a bare minimum of every 6 months. At your very next laboratory review, ask this direct question. What was my exact potassium number on this draw, and how does it compare to my baseline from 6 months ago? If your care team cannot pull up a clear trend line, you have a major gap in your fundamental care. Have you ever been told by a doctor or pharmacist to track your potassium levels while on these drugs? Drop a comment below and share your experience, because you will be surprised to see how many thousands of seniors are navigating this exact same blind spot. Let's transition to amlodipine and break down one of the most widely misunderstood side effects in all of modern medicine, which impacts up to 10% of patients taking this drug. This is severe lower leg swelling. Linda Hargrove was a 73-year-old former postal worker living in Richmond, Virginia. She had been taking amlodipine for 4 years, and for almost that entire duration, her lower legs and ankles were severely swollen. This was not just a little bit of evening puffiness. Her ankles were swollen to the point where she had to completely stop wearing the normal shoes she had worn her entire adult life. She brought this up to her primary physician during 2 separate checkups. Both times, she received the exact same casual answer. That is just a standard side effect of amlodipine. It is completely harmless, so do not worry about it. Linda trusted that authority. She adapted her life around it, bought wider, oversized shoes, and spent her evenings elevating her legs on pillows. She accepted it as her new reality until one hot afternoon, when the fluid retention became so incredibly severe that her daughter panicked and drove her straight to an urgent care clinic. There, the medical team discovered that the chronic swelling had been massive, masking a deeper, progressive circulatory decline that had been left unmonitored for over 12 months. Peer-reviewed data published in the Journal of the American Heart Association confirms that amlodipine-related leg swelling impacts a significant percentage of senior patients, climbing drastically with higher dosages and advanced age. In a busy clinic setting, this swelling is often brushed aside as a cosmetic annoyance, but if you look at the fluid movement of the body, it is far from harmless. When amlodipine relaxes the small arteries in your legs, blood rushes down into your lower tissues more freely. However, the veins, which are responsible for pumping that blood back up against gravity to your heart, do not relax or widen at the exact same rate. This creates a structural fluid imbalance. You have more blood volume coming down into the lower limbs than the veins can quickly clear out. Pressure builds up in those tiny, delicate vessels near your ankles, and that physical pressure eventually forces clear fluid to leak out of the blood and pool directly into the surrounding soft tissues of your lower legs. Hear me clearly on this. This is not fluid retention from eating too much salt. This is not your kidneys failing. And it is absolutely not terminal heart failure. In the vast majority of senior patients, it is simply a predictable mechanical response to the fluid design of amlodipine. Now, here is the part that becomes genuinely dangerous. It is not the swelling itself, but how an uneducated patient responds to it out of fear. Some people see their swollen ankles and decide on their own to abruptly stop taking their pill without notifying their care team. Their blood pressure quietly climbs back up to dangerous levels while they falsely believe they have made a sensible choice. Others continue the pill, but drastically stop drinking water because they think they need to dry their system out. That is the wrong direction entirely. Severe dehydration while on a calcium channel blocker carries massive risks of acute kidney strain. The correct move, the protocol I want you to remember, is this. Leg swelling on amlodipine is a high-priority conversation your doctor needs to know about, not because the drug is toxic, but because alternatives are widely available. Often, a specialized care provider can transition a patient cleanly to an ARB, optimize the dose, or safely combine lower doses of two different classes to clear the fluid retention completely. Did your doctor explain this potential side effect to you when you first started your medication? Let me know in the comments down below. Beyond these specific side effects, there is a major real-world scenario that almost never gets enough airtime in conversations about blood pressure control, and it directly impacts seniors more than any other demographic. What happens to these daily medications when you experience a common short-term illness? I am not talking about a major medical emergency that lands you in a hospital bed. I am talking about a standard stomach virus, a few days of persistent vomiting, severe diarrhea, a temporary loss of appetite, or simply a brutal heat wave in the middle of summer where you experience heavy sweating and fail to consume enough fluids. The moment your body enters a state of dehydration for any reason, the exact same daily dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated system begins to behave in a drastically different manner. Because your overall blood volume has dropped due to fluid loss, your resting blood pressure can suddenly plunge too low. Simultaneously, your kidneys, which are already working overtime to conserve moisture due to the dehydration, become incredibly vulnerable to chemical stress. Dizziness, profound physical weakness, fainting spells, or acute kidney strain can manifest far faster than most people ever expect. The medication in the bottle did not change at all. Your body's internal environment changed, and the drug is now operating under physical conditions it was never designed to handle. This is one of the most critical, practical safety instructions I can deliver to you today. Illness changes the pharmaceutical rules entirely. If you do not possess a clear, pre-established plan for what to do when short-term illness strikes, whether to temporarily hold a dose, when to directly contact the clinic, or what specific symptoms should trigger an immediate emergency visit, you are leaving a massive gap in your personal safety. That emergency plan is something you should actively secure from your prescribing doctor before you ever find yourself needing it. At your very next routine checkup, ask this question: what exact steps should I take with my blood pressure prescriptions if I contract a stomach virus or find myself unable to keep solid food and liquids down? It is a life-saving question, yet it is almost never asked. Has this ever happened to you or a loved one during a summer heat wave or a stomach bug? It is an essential discussion to have. Let's look at another incredibly common sequence that slips through the cracks because patients do not view over-the-counter bottles as real medication. Imagine you have a difficult week where your arthritis flares up aggressively, your knees are aching, or your lower back feels completely stiff. You head to the local drugstore, walk down the aisle, and pick up a bottle of standard ibuprofen or naproxen, which is something you have used casually for years, something available on an open shelf that anyone can buy without a prescription. Now look at the internal chemistry. You are taking lisinopril or losartan, perhaps alongside a mild water pill for fluid management, and you begin introducing daily anti-inflammatory pain relievers. When used regularly on top of these heart medications, this chemical combination dramatically restricts the baseline blood flow directly to your kidneys. In the context of even mild physical dehydration, your statistical risk of experiencing an acute kidney injury rises exponentially. This is not a rare hypothetical textbook scenario. It is one of the most frequent, entirely preventable admissions seen in emergency rooms. The reason it occurs is simple. Patients do not categorize over-the-counter anti-inflammatories as real drugs that can clash with their prescriptions. They view them as simple remedies for daily pain. But your kidneys do not read the labels on the bottle, and they do not care if a pill came from a doctor's prescription pad or an open retail shelf. They respond strictly to the underlying molecular chemistry. If you routinely use these for arthritis or joint pain while taking any of these 3 blood pressure prescriptions, you must initiate that safety conversation with your doctor. Safer alternatives, such as targeted topical treatments, acetaminophen options, or physical therapy tracks exist that completely bypass the kidney filtration risk. You do not have to live in pain, and you do not have to silently endanger your organs. This brings us directly to a symptom that sounds incredibly minor but carries catastrophic physical weight. This is dizziness. That brief, wobbly moment when you stand up quickly from a deep couch or step out of bed in the morning, where the world tilts for a single second, you grab the doorframe to steady yourself, and then it passes, leaving you thinking you just got up a bit too fast. For millions of older adults managing their blood pressure, this brief wave of lightheadedness is a regular weekly experience. And it is almost universally left out of medical conversations because it seems too minor to complain about. But hear this absolute truth. In an older adult, a single second of dizziness is all it takes to cause a sudden fall. And a sudden fall is all it takes to cause a severe bone fracture. And a fracture, particularly a hip fracture after the age of 70, can completely derail an older adult's health trajectory, setting off a sequence of immobility and physical decline that takes years to recover from, if recovery happens at all. This isn't alarmism, it is physics and biology operating together in a way that demands absolute respect. The lightheadedness occurs because your blood pressure medications are executing their job, which is forcing your baseline pressure down, When you transition from a laying or sitting position to a standing position quickly, your cardiovascular system cannot instantly compensate for gravity. Your blood pressure briefly plunges. The volume of blood reaching your brain momentarily drops, and you perceive that drop as a tilting sensation. The immediate behavioral fix is simple. Rise slowly. Sit on the edge of your bed for 10 seconds before standing up, and always hold onto a stable surface when rising to give your body those extra crucial seconds to catch up with the positional change. But beyond that physical adjustment, if you experience dizziness regularly, or if you encounter a wave of lightheadedness that results in a near fainting spell, that is an explicit signal that your current dosage or medication combination requires an immediate review. Silence on this issue is a massive, unacceptable safety risk. Let's address the profound anxiety and impulsive decision-making that occurs when monitoring blood pressure numbers at home. Your blood pressure is not a static, frozen number. It moves dynamically throughout every single hour of every single day in response to dozens of everyday variables. How many hours of sleep you managed, whether you consumed a cup of caffeine, if your joints are currently in pain, whether you are anxious about the reading itself, if you just walked in from a hot outdoor environment, or if you spoke out loud right before the cuff inflated, all of these factors shift the digits. A single elevated reading on a random Tuesday morning does not mean your morning medication is failing. Similarly, a single low reading on a hot day does not mean your prescription is suddenly too strong. What matters is the consistent pattern over time, measured under identical controlled conditions, using the exact same arm at the same time of day, after 5 full minutes of quiet, unhurried rest, without rushing or talking. When patients monitor inconsistently and react emotionally to a single isolated digit, the subsequent decisions are almost never good ones. This includes taking unprescribed extra doses out of sudden fear, or skipping a critical dose because a single reading looked optimal. Monitor with a strict method, track the data over a 2-week window, and bring that physical log to your next evaluation. Let long-term patterns, not short-term panic, guide the healthcare conversation. Remember, these maintenance medications execute their protective work through a steady, unbroken presence in your cardiovascular system, not through sudden spikes, emotional gaps, reactive extra doses, or skipped days. Amlodipine, Losartan, and Lisinopril are not rescue drugs designed to be taken reactively like an aspirin after a headache appears. They are long-term structural stabilizers. Let us close by returning one final time to Arthur Jenkins, the retired mathematics teacher from Ohio, who was entirely convinced that his unexpected physical decline during the heat wave was just an unpreventable sign of aging. His new care network did not change his primary diagnosis. Instead, they carefully optimized his daily dose and cleanly transitioned his protocol into an alternative class that perfectly aligned with his lifestyle and baseline hydration needs. Within just a few short weeks, his mental clarity returned completely, and those sudden, frightening spells of dizziness inside his backyard workshop vanished entirely. He safely returned to his passion for building oak furniture. He called his family that evening and told them, "I honestly feel like I just got years of my active independence handed straight back to me today." Arthur's blood pressure remains beautifully managed and protected, but now the static number on the clinical chart and the real, vibrant life he is living out in the world finally match up perfectly. The ultimate lesson to carry with you after this video ends is this: a blood pressure medication should be taken to help you live a better, higher quality life, not just a numerically longer one. If your daily pill is successfully managing a digit on a computer screen, but it is quietly draining your daily energy, stealing your natural balance, clouding your mental clarity, and destroying your personal confidence, that is not comprehensive healthcare. That is a dangerous physical trade-off that you never intentionally agreed to, and you have every single right to question it. The best blood pressure for your body is never simply the lowest number on the page. It is the number that keeps you upright, safe, and completely independent. Please share this data with someone you love and hit the subscribe button so you never miss our upcoming analytical reviews. My name is James Bennett, and I will see you right here in the very next review. This content is for educational and informational purposes only. It is not medical advice, diagnosis, or treatment, and should never replace guidance from your doctor or healthcare provider. Please consult a licensed physician before making any changes to your diet, medication, or health routine.